Good afternoon. Welcome to the UWA Anthropology Sociology Seminar Series. This semester, we will have a mix of speakers from interstate, even international speakers, as well as our PhD students, PhD candidates sharing their research. First of all, I'd like to acknowledge the Wajak Nyungar people as the traditional owners of the land I'm sitting in here in Crawley, Perth, where UWA main campus locates. The Wajak Nyungar remain the spiritual and cultural custodians of their land and continue to practice their value, languages, beliefs, and knowledge. We are honored today that we have our speaker from our neighboring country, Indonesia, Rizky Fillaili, or Kiki. She's from the SMERU Research Institute. I will read a bit about SMERU from the website. The SMERU Research Institute is an independent institution for research and public policy studies based in Jakarta, Indonesia. SMERU conducts qualitative, quantitative, and mixed method studies on various socio-economic issues affecting Indonesia's poorest and most vulnerable people. And the Institute work focuses on areas of socio-economic research, which are fundamental importance to contemporary development issues. And the bio for Rizky is a senior qualitative research at the SMERU Research Institute, been working on poverty, vulnerability, and socioeconomic impacts of crisis research for the last 15 years. Rizky is also holding a bachelor degree in sociology and master degree in development studies, currently completing her PhD at the Australian National University, and her thesis is Community Resilience and Adaptive Capacity during flooding in the Greater Surakarta Area, Central Java, Indonesia. So we're going to have 30 minutes of presentation from Rizky, and after that, we will have question and answer session. This session will be recording and uploading on our YouTube channel, UWA, on Anthropology, Sociology Seminar Series. So, Rizky, the time is yours.
Yeah, thank you, Mbak Tari. Hello, everyone. Thank you so much for this opportunity. Let me just quickly start my presentation and share the screen. So today I'm going to talk about the research that has been conducted by SMERU in the past 3 months about COVID-19. It is actually a series of research. We have 8 different topics related to COVID pandemics, and community resilience is one of the topics that we've been doing so far. We got sponsored from KSI, DFAT, and some of the research that we've been doing in these topics has been published in form of research notes, policy briefs, also a feature story. So everyone who are interested to read more can visit our website and download the publications. So today I'm going to talk about community resilience, especially among the vulnerable groups during the COVID-19 pandemics. I'm focusing on social-cultural resilience on those 2 factors, and while also acknowledging other factors that makes communities resilience during this pandemic. It is a rapid assessment, meaning that it is a very short ongoing, only 3 months. And because of this pandemic, we didn't go to the field, of course, and then we used a phone interview to collect the data. So before I start into the research, I just want to give you an overview for those who are not familiar yet with the COVID status in Indonesia. This is the data that I gathered from the official website from Provincial Jakarta, showing that the numbers of confirmed cases at national level keeps increasing, as well as in Jakarta. Currently, there are more than 100,000 people who got infected by COVID, with numbers or percentage of that reached almost 5%. This is actually quite high, even though we've been able to reduce numbers of that compared to 2 or 3 months ago when first cases of COVID has been just detected in Indonesia in early March. We can see here that the numbers are actually worrying or alarming, because from the graphic that I will show, it keeps increasing since March 19 to July 29. So if other countries have seen some reduction, including Australia, in numbers of cases, but in Indonesia it is not. We can see from the graph here, even though the numbers of people who have recovered from the infections are growing, but the cases are also growing, meaning that actually we are nowhere to be able to manage the pandemic. Here is the national trend and also the Jakarta trends. For example, the red line here is showing the trend or the cases at national level. You can see that we see the cases are hiking, like the spike. There is a spike in number of cases, since actually when the central government has easing some restrictions in social economic activities of the community. We've been the government has been imposed a lockdown. We didn't call it a lockdown, but a partial lockdown for 2 months. That was during and right after the Idul Fitri break. But then right after that, the partial lockdown ended, and then since then we see the numbers of cases of COVID rising is quite high, and the numbers of daily cases also definitely rising. We've been having a few daily record when numbers of infected cases have reached more than 2,000 per day. It is shocking, because it shows that the pandemic is still going on, and even we don't see where this is going, like when this is going to be over any soon. So having these numbers in mind, it is also important to see how government responds to the pandemic. Here I outline several government response or policies to respond to the pandemic. For example, the government imposed partial lockdown. Here in Indonesia, we call it PSBB, or Pembatasan Sosial Berskala Besar, large-scale social limitation. And also, we established a COVID-19 task force, both at national and central level, national level, and also at the provincial and district level. And then also, we are introducing, right after the PSBB or large-scale social limitation has come to an end, we're introducing a new normal narratives. And a few weeks after, the government then changed their response and introducing a new terms. It is called AKB, Adaptasi Kebiasaan Baru, means that adapting the new practice or behavior. And during the pandemic period, or that has 5 months, the government has launched and delivered several social assistance program and social protections program to the community. So these are among the government responses to the pandemic, and each of the responses are actually entangled, as I will show you in this next slide. Entangled, and also some conflicting between what happened at the national level with the national government policy and what happened at the local level with the local government policy. Sometimes they are conflicting, sometimes they are not coordinating well, meaning that what happened at the national level doesn't implement directly at the local level, or the local government implement their own policy that doesn't directly connect to what has been suggested by the central government. Also at policy level, we see some like contestation between economic policy and health policy, while on the other one side, the government tries to enforce the health protocols among community, to obey their suggestions to wear masks, to do some physical distancing, to do working from home or school from home. But on the other side, government also wants to recover the economic faster by easing some restriction, by opening businesses, and also opening shopping malls, markets, etc. That everything is actually put more risk into the people because the pandemic is still ongoing, as you can see from the graph before. So how is the condition in the community? This is what we did to see what is actually happening in the community, especially among the vulnerable group. So the study is looking at 4 types of communities that we consider vulnerable. The objective of the study is to understand socio-cultural factors of those vulnerable groups during the pandemic. And by that, we see that whether the socio-cultural factors can contribute to build their resilience. So the 4 communities are adat community in Badung, Bali, urban community in Jakarta. We selected 2 urban community in Jakarta. One is in the periphery of Jakarta. It represents a middle class kind of community. And the other one is urban community in inner Jakarta. It represents a lower class and densely populated community. And the other community is migrant community. Like we collected some information from migrants who are working in Jakarta but living in Java, in Central Java, in Eastern Java. So those are types of community that we are considering vulnerable groups. We conducted the study from April to June to 2020, and the methods, as has mentioned before, is collecting data through phone interviews. So this research tried to answer 3 research questions. One is how community risk perceptions to the pandemic. Second, how do the communities adapt to pandemic? And the third is what are the coping strategy implemented by the community during the pandemic. This research question is trying to answer or to understand more about community resilience, because resilience can be seen from the community risk perception, how well they are adaptive, and also their coping strategy, whether it's a long-term or short one. So I want to share through this slide how we collect the data for this study. Firstly, because we didn't go to the field directly, we tried to obtain contacts through our personal networks. For example, I have a nephew who lives in East Jakarta, who happen to live in area that are densely populated, a low income kind of community, and also community that are prone to flood. So from her, I tried to connect to the local leader there as a gatekeeper. And there from the gatekeeper, from the community leader, I tried to connect to several other community members to be our informant in this study. From there, then we make appointment through WhatsApp, through SMS, and we did the direct call, and also it is recorded. The durations of the interview lasted from 60 to 90 minutes, and we do some of the interview several times. It depends on the availability of the informants. What we learned from this is that some drawbacks, that we cannot do some direct observations to the community behavior. For example, when they said that, oh, some people didn't wear masks, or we actually following the health protocol, we wash our hands, we wear masks, we didn't go anywhere during the lockdown. But the thing is that we cannot confirm whether what they are saying is true or not, or what are the common behavior in the community. That was important or the major drawbacks from this kind of study that relies on phone interview. But on the other hand, we see some advantages because this is a rapid assessment. We can still get reliable and quality data, and we can actually reach far areas. For example, we can talk to people at Badung in Bali without having to go there. It's very low cost, and also we can talk like to many people, and because they have time at their hand right now, because they don't go out much, they didn't go to work, they are more than willing to talk to us also. But of course, we provide some compensation for their time. So if anyone wants to ask more about the methods, I'll be happy to answer during the question and answer session. So here's the result about community risk perception. This picture I got from the community leader in Jakarta Timur, in East Jakarta, during the lockdown period. This is actually taken at night during the Ramadan time, where you can see people are still gathering in the community open area without wearing masks. What did they say about this? That I hang out with my neighbors, I am healthy, they are too, so we are fine. We just okay to hang out together with the neighbors without having to wear masks, without having to worry to get infected by the virus. And from the study, we encounter several community perceptions. That's the perceptions that the people at urban area have. While in other community that is in the peripheral area, they have a higher risk perceptions because the neighbor got infected by the virus. So they are more cautious, they are more worried. So they are more compliant to the health protocols compared to the community that doesn't have direct connection, or doesn't have someone that they know that got infected by the virus. In adat community in Badung, Bali, it's also different. The risk perceptions, they're even higher because the community there are facing sanction from adat. If they broke the law, like for example, they keep gathering, they keep going out to the market, then the adat law will give sanctions to them. They feel ashamed, therefore they prefer to follow the health protocols. So different community present different kind of risk perception. Among community or migrant community who are working in Jakarta, for example, they follow the rules of health protocols, what has been implemented by the workplace. So they follow the protocols in order to be able to go to work. And those are the things that makes compliance level at the community level is so different from one place to another, because everybody or every community has their own perceptions of risk that affects their behavior and compliance to health protocols. The second thing about this, that we also see that their perceptions are changing over time. Like for example, during the early lockdown, they have a higher perceptions of risk, but then over time they get bored, and also economic pressures make them ignoring all the health protocols. Economic pressure, as I mentioned before, and government response to the pandemic also affect community perceptions to pandemic risk. The second answer to the research question is community adaptation. What is interesting here is that some people and community actually adapting better at the beginning of the pandemic. For example, we can see here some communities are imposing their local lockdown. They put some restrictions, they check people who are going in and out their community, they check their temperature, they check their identity. Sometimes are they checking whether these people are wearing masks or not, to prevent the spread of the infection. So as we can see here from the quotation from the Desa Adat community in Badung, so long before the government imposed PSBB or the local lockdown, we at the village already implemented regulation. Wearing masks are mandatory. We prohibit large social gathering. Also, we monitor the village, that we warn people if we identified someone who are not following the regulations, etc. So at the very beginning, communities are adapting. But the thing is that we found the adaptation is conflicting between individual and community level. But before that, I will give you an example what individuals are doing in terms of adapting at the beginning of the pandemic. Of course, they are wearing masks. They said that they wash hands frequently, and they do physical distancing. Even some are innovating on the way they do business. Like one seller, they use a wooden stick to give the goods to the clients in order to maintain physical distancing. That's far that the community can do, or a person, an individual can do to survive the businesses. At the community level, we see some initiatives that the local lockdown, the community watch, temperature checking, and community disinfectant, as you can see also from the picture. So this is what happened in East Jakarta at the community, a middle class community, where they regularly disinfected the area like once a week, and they collect the money to buy the disinfectant, and they do voluntarily work together to spray the area to make it clean and away from the virus. But the thing is that, as I mentioned earlier, this is temporary, because when we make repeated interview to the person who lives there, they said that the disinfectant is no longer there. They didn't do disinfectant anymore. Like they've already eased the lockdown. Like people are able to go in and out the area more freely now than before. So there's a problem in terms of the continuity of community adaptations to the health protocols. It is temporary, while actually it is expected that community keep on doing the adaptation, keep on doing the watch, because we still see the pandemic or the infection rate going up. Also, it is conflicting between individual, community, and the workplace base. For example, at the individual level, they said that they have obeyed the rules, like that they didn't go out after 9 p.m., for example, but the neighbors are gathering. The mosques are still holding a prayer, and they didn't enforce a physical distancing. So it creates a confusion among the among the community members, the confusions that leads to their compliance. Like, okay, I don't have to do this because others don't do that too, or people are already relaxing. Why do I have still my wearing my own mask? That's kind of things, conflicting things at what happened at individual, community, and work place-based level create confusion, and also it affects community compliance to health protocols. We also see that the adaptive capacity at the community level, it depends on community organization capacity to enforce the long-term adaptation. For example, in a community where they are being flooded regularly, they already built their capacity to organize, so that when it comes to pandemic, for example, at the initial period of the pandemic, they are able to rely or draw on their organization capacity to collect people, to work together, to do community watching together, and also, for example, to distribute the assistance from the government without any conflict in the community. So that kind of organization capacity is important actually during this time. But the thing is that everybody has such capacity. It has to be built and has to involve a leader in this matters, and also it needs a coherent policy at the national to subnational level, even to the local neighborhood or RT or RW level. The third question that we try to answer is about the community coping strategy. Here's the picture of one of presidential assistants to poor and vulnerable group. I think this is the third round or the second round, I forgot. I actually received this because in my community, the leader distribute the assistant equally, regardless the socio-economic status of the community members. So everybody in my community received this kind of assistance. So it consists of 25 kgs of rice, 10 packs of instant noodles, 10 cans of sardines, cooking oil, 1 kilogram of cooking oil, ketchup, and tomato sauce. And I think previously in this first round, there were also soap, mask, and biscuits. So community received different kinds of assistance in different amount and every time. The thing is, the question from this is whether is it enough to cover the community needs during the lockdown, and how long does it last? This is another question that we need to answer. So the range of options that we encounter during the research in terms of community coping strategies, that first, community reduce their food consumption. This is the most common strategies. Like because they have less income now, they have to reduce their food consumption down to, for example, eating just rice and vegetables for people in the rural area, or eating rice with instant noodles or at least with eggs. And the second strategy is pulang kampung, or going back to the village. This is mostly applied by the migrant workers because since they don't have any more income in urban area where they work, they went back, they live in their village, and they got supported by their family members, by their parents, and they mostly rely on their own saving, which is only lasts like for 1 month, because they mostly are casual laborers or factory workers living on a minimum wage, and also sharing the burdens with the family members, and eating whatever they can have from their own yard, like a minimum that they can get. For small businesses, for example, they try to reduce their production costs. Some are selling their assets. Some are firing their workers. And some are waiting for another opportunity to open their businesses, while again relying on support from their parents or relatives in the village. Some workers try to change the occupation. For example, before they are working as factory traders, they are now looking or trying to sell fruits in the village, because during the Ramadan time, people are still buying food, buying fruits, and from there, even though they could not get more, but they're still able to live for the day with the income from selling fruit. And also the relying on social assistance from the government. It is considered beneficial for the poor and vulnerable groups, although again, migrants workers are excluded from this social assistance because they are working, they are staying in Jakarta, for example, they didn't register as Jakarta citizen, so they didn't get the social assistance. They sometimes miss from the distribution. So I talked to one of the factory workers in East Jakarta, and she said she didn't get any social assistance from the government, and she relied mostly from the wisdom from the local leader. Sometimes the local leader, knowing the situations, they give the assistant like take turn, like for example, this time I will give this assistant to this household, but next time the other household will get it. So there is no really government mechanism to reach these migrant workers, meaning that migrant workers in this regard are the most vulnerable one during the pandemic. So this is a picture of when people are distributing social assistance in East Jakarta. It is actually not from the government, but from the wealthier community member who collect some money and they buy some stuff like instant noodle, you can see rice, sugar, and put it in boxes on the plastic bag to be distributed to the less fortunate groups in the community. So it is also one of the initiatives that are emerged during the initial pandemic. But the thing is that we need to check whether this practice is still ongoing or not, because this is spontaneous act, and there is no mechanism yet. And also the economic situations are changing. Some people who are, for example, better off before now probably have a more difficult condition that they cannot, contribute anymore to this kind of solidarity work. So in this regard, while in the economic terms, people are actually coping. They are coping, they are resisting, and they are not yet building their resilience to the pandemic in the economic terms. So the conclusions of this study are threefold. First, in terms of community risk perceptions, it changes and it is contested. Community tend to have low risk perceptions. It is because of the social cultural backgrounds, the social cultural context, and also, but it's also because as a reaction to government responses to the pandemic. So we need to do something more seriously in this regard, how to maintain the community risk perceptions to be as high as possible and to be as true as possible. Secondly, community adaptation to health protocol is temporary. This is also worrying and alarming because the pandemic is still ongoing and it's conflicting between various levels of adaptation. And the economic pressure is also increasing. All these factors together have created or increased false sense of security in the community. And it will challenge community resilience in the future. With the increasing false sense of security in the community, it becomes more difficult for the government and for the community member itself to build their resilience in the future. Based on the studies, we recommend some policy options. First of all, to respond to the risk perception, the community risk perceptions, we think it is important to improve risk communication strategy to communities to be able to reach the vulnerable groups and those at risk of getting infected. Basically, and most importantly, to maintain the high risk perceptions of community of the risk of the pandemic. Second policy option is we need to support community adaptations to enhance, to make the adaptations long-term, to follow the health protocols during the pandemic. It required community participation at all levels to maintain their risk-informed behavior and adaptation strategy. And lastly, we also learned that it is important to develop a regular monitoring of community condition to generate a real-time data about community condition to inform decision-making process. We see that we have a problem here in the openness of the data of the cases, numbers of cases, locations. That is actually important to create a high risk community risk perceptions. So we've been communicating this research results to BNPB in Jakarta. BNPB stands for Badan Nasional Penanggulangan Bencana. It is a national body that deals with any kind of disaster, and they mostly agree on our recommendations and also acknowledge the problems with the community perceptions with regards to the pandemic. And they have tried to solve also the problem. They're improving the communication there is communication to the community. They involve the local leaders to deliver the message. And they built a resilient village, for example, resilient community in several areas. But the thing is that those efforts needs to be monitored, how effective they are, and whether we need some changes in the approach to make it more efficient and able to reduce the infections or the pandemic. Thank you very much. I will end my presentation here.
Thank you, Makiki.
It's less than.
It's exactly 30 minutes.
Okay.
30 minutes, 3 seconds. Okay. I already have Pak Greg here. Okay. And then
Chris, it's Chris.
Yes, Chris, because it says Liz, sorry.
I know, I'm working on my wife's.
Oh, that's why. Okay, so we have Greg, and then Chris, and then Sam. Please.
Shall I start?
Yes, Pak Greg.
Yeah, terima kasih for that really incisive presentation. I have a quite general question. If we look back at some of the previous crises, the monetary crisis in 97, 98, a decade later, the global recession, urban communities were more vulnerable. People in the villages often came out much better. And you mentioned in this particular presentation that the most vulnerable community in the Jakarta area were the migrant workers. And you mentioned also that one of the benefits of looking at the Badung case in adapting to the situation was the adat sanctions in the rural context. So I'm wondering, given this history, are there any policy discussions that talk about the need, given recurrent crises, disasters, to promote deurbanization, to have policies in place that will try to reduce the incentives for labor migration to cities and such, and to try and build up more infrastructure incentives to stay in rural contexts so that there is less vulnerability to these recurrent crises? Thank you.
Thank you, Pak Greg. Should I answer or gimana?
You want to answer now or collect some questions more? Like
Can
to
I collect? Yes.
Okay, Chris.
Oh, okay. Thank you for the presentation, Rizki. I wanted to ask a question a little bit like Greg's. I get the impression from the data that the nationwide effects are not too different from those in Jakarta, but I could be mistaken. You might comment on that.
Yeah.
And my second is a question. I noticed in the slide on data collection, you had the word gatekeepers there, and I wondered what effect they had in the kind of quality of data that you collected. Thank you.
Yes. Yeah. Thank you.
And then the third one, Sam.
The awareness aspect of it. But I was wondering, so in the West, there was a period of a couple of weeks early on where there was almost total media saturation of news related to coronavirus. And I was wondering if a similar pattern was present in Indonesia, or whether it never achieved the same level of dominance. And similarly, I was wondering if there was ever sort of a rhetorical sort of tool like flattening the curve, which had a period of ascendancy, as a very influential way of getting people to adapt their behaviour to desired ways of mitigating the coronavirus, and then collapsed over time due to sort of internal tensions. Thanks.
I think you can answer first, these first three questions.
Yeah, thank you for the questions. For Pak Greg, I completely agree with you that urban community are more vulnerable, and it once again shown by this pandemic. But whether there is a policy discussion so far, whether to promote people to stay in the village through infrastructures, there are infrastructures development in the village. It is ongoing with Dana Desa and everything. But the thing is that we don't know yet whether it stops people from going to the urban area. Because, for example, when I talk to one of migrant workers, she is a very clever one. She works as a health sales, health facility and sales, as a sales marketing sales. When she went back to her village, she only stayed for 2 months before deciding to go back to Jakarta to find another job. So she see the opportunity still in the urban area, not in the rural area. And because even though the emotional connection are still in the rural area, for example, she is building their house in the rural, but still see the income are in urban area. So I don't see, like, when people are saying that they are looking for more opportunity, they are looking for more opportunity in urban area, but not in rural area. And whether there is a policy that try to translate that into policy, I didn't see it that way. Okay, for Pak Chris, the nationwide effect, that's so much different. It's so true, Pak, because Jakarta contributes the highest to the national figures. The highest infections, the highest numbers of deaths are coming from Jakarta. We only, East Java only surpassed Jakarta only a few weeks or few days before Jakarta back to top. So what happened at the national level is actually reflecting what happened in Jakarta. But it is also worrying because Indonesia is not about Jakarta. It's also about other places, small places, islands, remote areas that doesn't have a facility as much as Jakarta has. So when the virus gets to that kind of area, we don't know what will happen. So the second question is the effect of gatekeeper. You are absolutely right, Pak, because we encountered this, and the role of the gatekeeper is actually big. We encountered this when we did the interview in densely populated in Jakarta Timur, where the gatekeeper is the local leader, and he gave one of his community member, which is smart and a contract worker, that actually approve of whatever the leaders are doing. You know, so this is the time when we need to triangulate and look for another resource, and I have to go around the way, and to get more people to talk, to be able to get a complete pictures of the community. And for Pak Sam, it's about saturations of data and flattening the curve. I apologize if I didn't get the questions correctly, but the thing is that all those terminology, it doesn't reach the poor and vulnerable groups well. So people don't understand what is actually happening. Like, they know that the virus is there, but they know what our efforts are needs to be taken. So it's just terminology. So like the new normal narratives that imposed by the central government, it also doesn't really been understood well as expected by the government, for example.
Right. So, but I guess my point there is that even in the West, there was a very large extent to which people didn't understand what was actually expected of them, but it still managed to mobilize a lot of sort of behavior. So do you think that didn't work in the Indonesian context?
Sorry, Sam, I didn't get your question well because the connection is not good in my...
Yeah, it's not. No, I'm sorry about that. I mean, do you think that this played a role in media saturation, or do you think this is mostly down to the role of sort of community figures being able to mobilize people and to get people on the same page as them?
Well, because at the community level, false news is also a lot about this coronavirus, and it counters the narratives from the government or from the epidemiologists or from the scientists. So we cannot really say whether, you know, this affects this kind of behavior or just the two behavior comes together and affects certain kind of behavior.
All right. Thanks.
Okay, I'm open to another 3 questions. I already have Katie here. And then I actually also have a question, if it's okay. Okay, so Katie, and then me, and then do we have other questions? If not, then I'll just, oh, Ibulin. Okay, so Katie.
Thank you. And I just wanted to say it's very impressive how quickly you've mobilised to conduct this research and then to be presenting such a coherent and interesting presentation. So well done to you and your team. It's great.
Thank you.
I'm really interested in the idea of risk, and I think it's been such an interesting thing to see. I'm sure you and many of us have been communicating with friends all over the place, as well as seeing the news and seeing, you know, in the US, there's been a very sort of defiant ideological divide around perceived risk, where, you know, those on the conservative side of politics tend to downplay it and vice versa. And I've had a lot to do with the people that I worked with in Botswana who, as a rule, it was something I wrote about years ago, they take a lot of risks in their daily lives, and they really, for them, freedom is prioritised hands down over risk. And so it's really interesting to think about the kinds of, and then obviously there's been another discourse that's been unfolding, particularly in Melbourne, around generational differences in perceived risk and young people, you know, given the specifics of the disease, as well as that general sense of invincibility I think people have when they're young. So I was wondering, and I was also really interested to hear you talk about adat and how that was impacting compliance. So I was wondering if you could tell us your thoughts about, I guess, what kind of broader sort of religious ideologies or ideas about relationships to death and you know, lives thereafter, and those kinds of bigger cultural patterns that might be impacting the way different portions of the community or the community broadly are conceiving of risk. Thank you.
And then, like, from me, the questions is about, you mentioned about how there are changes in the community with all this pandemic situation happened. And then I'd like to know what happened with the, you know, like regular health checkups that usually a member of community should have, like are these also disruptive in a way? Because, you know, like all health facilities, from the news I've learned, all health facilities in Indonesia is really occupied with the pandemics. And then how the community or community member, especially those, the most vulnerable ones, deal with that. And you also mentioned about there are sharing of burden in the communities and also the family. What kind of burden sharing that you found from the field?
Yes,
that's my questions.
Thank you.
And then we have Bulin.
Hi, thanks, Rizky. That was really an interesting. That's my picture.
Thank you.
Really an interesting presentation. the first question is about testing. I know it's not really what your research is about, but at the beginning I know the level of testing that was being done in Indonesia was very, very low. And then it was higher in Jakarta than elsewhere. And I guess that's why one reason that the figures are the way they are.
Yeah.
And I assume also the description of deaths, because the deaths in Jakarta are almost the total national deaths, right? So that's just crazy.
Yeah.
So has the level of testing been increased since those early days? Yeah. But then moving on to your research, actually my questions kind of both follow the previous question. So one was about religious interpretations of the pandemic, and that sort of follows on, crosses over with the adat, I suppose, but whether there's kind of talk about blame or, you know, sinful behaviour or anything like that, and or is it fate, and is the sort of the global aspect, how is the global aspect of it being interpreted? A little note on Bali. So I've been in communication with people in Bali, and someone was saying how there was terrible traffic jams in Bali, and they're all local people. So on Sunday, everyone's out and about, you know, having picnics and being tourists. It didn't sound like as though Adat was having much impact.
Yeah.
I've already forgotten my other question, but anyway, they can do.
Yeah, okay. Yeah. So shall I answer?
Yes, please.
Yeah. Thank you for the question, Katie. Yeah, it's interesting, and this is actually another discourse, and it requires sets of research on its own to understand the perceptions among different generations. In terms of religious ideology and cultural patterns, it really affects the way people respond to the pandemic. For example, in Eastern Indonesia, in Sulawesi area, most of the behavior that doesn't believe COVID exists are coming from there. It might have to do with their religious affiliations. They are Muslim mostly, but they also like very strong in practicing the religious belief. For example, if someone's or family members died, they have to be buried according to their own ritual, according to Islamic ritual practice, and they don't accept that those family members are being buried following protocol of COVID. And you know, and also at a more general level, the religious ideology, I've seen it many times, like when your time comes, it comes. It doesn't matter whether you die because of COVID or because of other disease or from by accident. As long as I can still work, I need to work because I may die because of hunger, not because of COVID. That kind of, so it's another conflicting thing that happens at individual level, then that affects their behavior towards the pandemic and also their risk perceptions. I don't know, but the agricultural ministry has just launched eucalyptus oil. They put it as a necklace, and the people are wearing that, and they think that it can prevent them from getting the COVID. You know, so many levels of people knowledge, behavior, and also ideology that are competing with each other and affect their perceptions towards the risk. On the second questions of Mbak Utari, yes, the health services are greatly disrupted because many of the big hospitals are now has been a COVID hospital. So they are no longer accepting regular visit health checkup. So people needs to, you know, for some time not going to the hospital of fear of being infected, or they look for another way, like for traditional remedy, like my mother, looking or eating jamu, or drinking jamu, or, you know, traditional healing, doing some massages, and or using application Halodoc, where you can consult online doctor, and the doctor will give you some suggestions, even prescriptions that you can, you know, buy in a nearby over-the-counter chemist. About the sharing the burden at the village level, it is mostly about consumption. Like for example, when people who are used to get, for example, a chicken seller in Bandung, Bali, he used to get 800,000 or $80 per day and down to only $10 per day, then he really needs to work out how it is sufficient for the whole family members, that they rely on their neighbors, for example, and also from assistance. And some are started to plan their own food to be able to eat, rice with vegetables at least. Is it answer your question? Does it answer
Yes.
your question? Yes.
Thank you.
And Ibu Lin, yes, the testing has increased, Ibu, especially in Jakarta, because Jakarta has so many labs, the most labs than compared to any other area. And also only in Jakarta that the number of tests has met the standard by the WHO. But the thing is that it's still a specimen test, not the numbers of people. So we still need to, to increase the test rate, especially in area where the infection rate is also high, such as in East Java, Central Java, and West Java. What else? The religious interpretations, blame, and sinful. What we heard is theory of conspiracy theory. Conspiracy theory that COVID is coming from China, for example, and also it doesn't really exist because here again, as what I said before, it conflicts with some of the government or hospital responses. For example, people hear that patient who died because of COVID might have been died because of other disease, but the hospital put it under COVID category because then the hospital will get some money from the government. So then it's make them start to think, is it really exists or not? Because probably it's just the way of the hospital getting more money from the people. Like once you get and diagnosed with COVID, then the hospital will get more money. It doesn't always have to do with religious interpretation, but then that's what happened. And in Bali, Bu, you are right. So I talked to people in Bandung like 2 months ago, and few weeks ago, the perceptions are changing. They said before, I can just sit in the middle of the street without having to worry to get hit by a car. But now it's so difficult to just cross the street because so many, cars and motorcycles. And you're right, we need to revisit again about the roles of adat, whether they are, relaxing some of the regulations, some of the restrictions, or people are getting bored, or because also the governor of Bali saying that Bali is prepared to welcome more tourists by now. Yeah.
Thank you. Interesting. Do we have questions? Question? No. Not until now. It's 3:34 already, so I think if we don't have more questions, I'd like to thank Mbak Kiki.
Thank you
for giving such a great presentation, and also for SMERU, and happy Eid Idul Adha again. Sorry that in this celebration you have to be sharing with us.
No worries.
Thanks a lot. We will still open this space to have a chit chat, and then if you don't mind to stay for a bit, maybe some people would like to just raise some questions to you. But after all, thank you so much.
Thank you everyone for the questions and the opportunities, Mbak Utari.
Yeah, thank you so much. Next week, we'll have also international speaker, Professor Christine Hein. I hope I pronounced it correctly, from the University of Surrey, UK. And she'll talk about online research as a research method. So thank you all for today, and have a good rest of the week. Have a good weekend too.